Good morning, everybody. First, I would like to thank the organizing committee and Dr. Ayman Abdel for their kind invitation. Today, we will speak about the myocardial strain and its importance in monitoring chemotherapy-related cardiotoxicity. The increased survival of cancer patients raises the likelihood that the patients will experience side effects of cancer therapy, with left ventricular dysfunction is the most important of which, occurring in 30% of the patients, with 5% of the patients having heart failure. 50% of patients having heart failure may experience incomplete recovery. So it's very important to make a display to optimize the strategies for those at high-risk patients, so cardio-oncology has emerged. The mechanism by which chemotherapeutic agent can cause LV toxicity, cardiac toxicity is different, but today we are concerned with this. Today we are concerned with this mechanism, the cardiomyocyte damage and heart failure. Two types of chemotherapeutic agents can cause this. Type 1, which causes irreversible, dose-dependent myocardial damage, with the great example of which is anthracycline, and type 2, which causes dose-independent but reversible myocardial damage, والجريت example فيها trastuzumab. European Society of Cardiology Guidelines 2023 formulated a risk classification for those patients depending on both the type of chemotherapeutic agent and the characteristics of the patients, whether it is, he has a coronary artery disease, a left ventricular dysfunction, arrhythmia, or whatever. So they postulated a risk classification according to both. It's very important to assess, it's very important to assess the left ventricular systolic function before cardiotoxic chemotherapeutic agents and during and after. With transthoracic echocardiogram is having the best accessibility, lack of radiation and functional testing which are available, with limitation of the variability between the operator acquisition and interpretation. Cardiac MRI having the best reproducibility but lacking in access issues. MUGA have a very good reproducibility, but its limitation by radiation exposure. Echocardiography of cardio-oncology should include both assessment of left ventricular size and function and right ventricular function, pulmonary artery pressure, and volemia. What about the assessment of left ventricular function for cardio-oncology? Testing for reproducibility, a study done in 2013, including 88 patients with breast cancer undergoing systemic chemotherapy with at least 3 serial echocardiograms. All the cardiograms having no change in the global continuous rate, yet there is a great variability in the ejection fraction measurement by different methods, with the 3D non-contrast method having the least variability. Another study postulated to examine the reproducibility, with 2 observers read the same studies twice each to assess for intra-observer and inter-observer variability. The result of the study confirms that 95% confidence interval for the 2D LV ejection fraction variability between the studies is approximately 10%. Surprising, this 10% is analogous to the 10% change in the ejection fraction that defines cardiotoxicity. So there is a limitation in the ejection fraction assessment for cardio-oncology. First, as a volume-derived index, it relies on geometric assumption and extremely load-dependent, thus leading to considerable loss of reproducibility. Second, it may be influenced by changes in geometry, whether hypertrophy or dilatation, and does not reflect the true LV contractility, so it is poorly sensitive in detecting declining ventricular function. So we proceed for strain analysis. Strain analysis, examining the myocardial fibers, depending on the myocardial fibers, is arranged in a longitudinal, circumferential, and radial manner, shortening that can measure this speckle tracking of each segment. A strain is a rate of deformation. Global longitudinal strain is the rate of deformation of the myocardial change in the length from base to apex during the cardiac cycle. Here is a three-chamber, apical three-chamber view, speckle tracking, examining the 6 segments of the apical three-chamber view. Taking the 3 apical views, apical 3-chamber, 4-chamber, and 2-chamber views, we get the global longitudinal strain. Here it is minus 16.9. Also, we can examine not only the longitudinal strain, the radial and the circumferential strain can be measured. This is an example of patients pre-therapy, pre-chemotherapy, 6 months after and 12 months after. After 6 months, the global longitudinal strain decreased to minus 17 from minus 20. The ejection fraction decreased from 61 to 51 to 55. This is didn't meet the criteria for cardiotoxicity, but this decrease of minus 3, it's relative 15% decrease. It met the criteria for cardiotoxicity. After 12 months, the decline in the ejection fraction met the criteria with more decrease in the global longitudinal strain. So global longitudinal strain detect the LV dysfunction earlier. The European Society of Cardiology and the ECAVI agreed that the significant decrease in ejection fraction to be more than 10% for asymptomatic persons, and it should be less than 50%. But for the ECAVI, it is the cutoff for the ejection fraction was 53%. They agreed for the global longitudinal strain that the relative reduction of more than 15% of the global longitudinal strain. So the recommendation for the latest 2022 guidelines said that echocardiography should be done as the first line modality. 3D echo is recommended when available. Global longitudinal strain is recommended in all patients with cancer having echocardiography if available. CMR is considered if the cardiac function, for the cardiac function when the echocardiography is unavailable or non-diagnostic. And study postulated 2022, they added LV ejection fraction and global longitudinal strain, but starting with the ejection fraction, or the patient have MRI in all the stages to compare, starting from ejection fraction. If the patient have CT-RCD, they found that this patient have a probability of having CT-RCD by MRI is 76%. If the patient has normal ejection fraction, proceed for global longitudinal strain. If there is significant change, significant decline, the probability was 16 or 7 according, there is a decrease in global longitudinal and the global circumferential or just global longitudinal. If the patient has normal ejection fraction, normal global longitudinal strain, normal global circumferential strain, the probability of having CRCD is as low as 1%. So this approach can be useful in patients with borderline or uncertain changes in the LV ejection fraction, where global longitudinal strain and global circumferential strain can be used as an arbiter to CT-RCD. This study showed that the global longitudinal strain changes in global longitudinal strain occur before LV dysfunction on cardiac MRI. Also, This study showed that the CTRCD occurring slightly earlier and in greater proportion of patients by cardiac MRI compared by 2D, 3D echo. It's important to detect CTRCD early for protection. Does it differs? Does the protection guided by global ignorance strain differs? A study compared both methods with the rejection fraction of global ignorance strain found that patient comparing ejection fraction of the patient taking cardioprotective measures guided by global ignorance strain showed just decrease in LV ejection fraction of 2.9%. Compared with that guided by ejection fraction, there is a decrease of ejection fraction from pre-treatment to at the end of the study by 9%. So it's important. To summarize, cardiotoxicity is a major complication of chemotherapy use. Patients at highest risk for cardiotoxicity include older patients with 2 or more cardiovascular risk factors, pre-existing cardiac heart disease, receiving high-risk therapy, the high-dose anthracycline, simultaneous anthracycline and trastuzumab, anthracyclines and VEGF, or anthracycline and chest radiation. Accurate assessment of the left ventricular systolic function is the key to monitoring the cardiotoxicity. The semi-annual technique like 3D ejection, semi-manual techniques like 3D LV ejection fraction and global ignorance rate, improving reproducibility. Strain analysis can detect subclinical left ventricular systolic dysfunction and predict deterioration LV ejection fraction. The integrated approaches with LV ejection fraction assessment and the strain aid in the diagnosis of CTRCD. Preventing CTRCD involves optimizing risk factors, encouraging exercise, initiating cardioprotective therapies, the ACE will beta blockers where approaching. Reduction in global ignorance can be useful. خلاص احنا the last slide.
1 minute.
20 seconds.
1 minute.
So reduction in global ignorance strain can be useful in triggering the initiation of cardioprotective therapies. Surveillance for cardiotoxicity should keep in mind not only the risk during therapy, but also years down the road. Thank you.
Thanks, Professor Amal, for this elegant presentation. And thank you for you all, and we will close the session. Thank you.